Hi, I'm Andrew Penn. I'm a psychiatric nurse practitioner and an associate clinical professor at UC San Francisco School of Nursing. In this first of 5 modules, we're going to start talking about bipolar spectrum disorders, starting off with epidemiology and terminology that we'll use in further modules. So the main thing I want you to take away from this is understanding bipolar and unipolar conditions as being on a continuum rather than being two different categories of illness. And so we'll talk about the concept of a bipolar spectrum as I go throughout this presentation, and also key differentiations from other presentations which may present similarly to bipolar disorder. We'll talk about effective medication treatments for bipolar disorder and how to use those safely, and also finally how to educate patients about their own condition and their families. So in this module, we're going to talk about some of the terminology that we use and why this diagnosis is so important and how common it is in the population. So this may be familiar to you, but let's just go ahead and get on the same page with terminology. Now, a lot of times I will draw a simplified version of this for patients, and I start by drawing a line in the middle of the paper, and I call this euthymia, and translate that for patients as essentially a normal mood and energy level. Now, if somebody has low-grade depression, we call that dysthymia, and if it becomes symptomatic enough that it causes significant impairment or suffering, we call that a full depressive episode. And conversely, a mild increase in energy and mood is referred to as hypomania. And sometimes it's simply energy, it's not mood. Sometimes the mood can actually be quite irritable, but there's a lot of energy and there's an inability to sleep, ranging all the way up to full mania, which is represented by this red line on the top. When somebody is in a full manic state, their energy is quite apparent, usually through their psychomotor activity and their speed of speech and their rate of thought. Now, just to make this a little bit more confusing, a very common presentation, though often not appreciated, is something called a mixed state. And you can see that in the middle of the diagram here where the lines appear to be going both up and down at the same time. And this is probably more common than we once thought. And this may represent a large majority of bipolar states. When somebody is not in a euthymic state, they may be in these mixed states. And in a situation like this, clinically, this could present as somebody having a lot of energy, but their thought content is very negative, very dysphoric mood, but unable to sleep, for example, very restless presentation. Important to catch that because it can be a dangerous state in the bipolar cycle. And one of the challenges with identifying bipolar disorders is that the DSM, as it's written now, puts a lot of focus on the polarity which we find the person in, rather than the overall big picture of cyclicity. So a lot of times people will talk about, well, this person can't really be bipolar because they've never had a manic episode. And it's important to understand that historically, we had a condition called manic depressive illness, and that was a designation for anybody who had recurrent mood symptoms, be they alternating between mania and depression, or even just recurrent depression. That was referred to as manic depressive illness. That was supplanted by bipolar disorder, which introduced some of this confusion. And it's important to understand that the DSM is simply a map. It describes the things we may see, but it's not a substitute for the actual territory. And so what we actually see in our office often does not fit neatly into these boxes that which we are presented with in the DSM. And it's important to realize that human beings are a lot more complicated than the DSM would lead you to believe. So the question then becomes, well, what is remission in bipolar disorder? If this is inherently a recurrent and cyclical condition, when do we say we're in remission? And I would posit that this is what that looks like. So when we have successfully stabilized somebody's mood, we have put a ceiling on their upper reaches of their energy state. So they may still get a little bit elevated, but they're not going to get up to that red line, that full red line of mania. And the same for depression. We put down a floor or a safety net. And that's a metaphor I'll often use with patients. I'll say, so you may have some cycling, but when you go down, you're not going to go all the way down to the bottom like you have historically. And more importantly than maybe the amplitude of the poles is the duration of what we call euthymia. So what you want is longer periods of normal mood and energy. And what this, you may not see this until the person's been on medication for a while, because let's say they only have 2 mood episodes a year. It may be a couple years into medication before they come back and say, you know, I used to have an episode every summer, and I would have one right around Thanksgiving. And I noticed last couple of years, I didn't have that Thanksgiving one. So we would call that less cycling, more time euthymic, and successful treatment. I would argue that this is as close to remission as we often get with bipolar disorder. It's really much more of thinking about managing a chronic waxing and waning illness state. And you know, we talk a lot about mood. We even categorize this as a mood disorder, which is misleading. And I really think this is an energy dysregulation syndrome. And so by that I mean that the amount of energy that we have, it can be thought of as like the locomotive on the train. And all these associated symptoms like mood, like the amount of sleep they're getting, the amount of activity they're having, how quickly their thoughts are going, and the direction of their thoughts, and possibly even their libido, is sort of pulled along by that boxcar. So when that's going up, those boxcars, of course, are going to follow. And then when that goes down, they again follow too. So when somebody is in a low energy state, they're going to need a lot more sleep. Their thought is going to be slower. They're probably going to lose their libido. They're going to be in a often dysphoric or negative mood. And it may turn out when the day is done that this is really an energy regulation disorder on the cellular level. There's a lot of interest in mitochondrial dysfunction in bipolar disorder, which would certainly make sense that the mitochondria in people, this particular finding found that folks with bipolar disorder had changes in the mitochondria compared to non-bipolar patients. And so it may very well turn out on a molecular cellular level that this is indeed an energy dysregulation disorder. Now, how many people have bipolar disorder? It really depends on how you define bipolar disorder and who you ask. The most conservative estimates put the population at about 1.6% of the population. And then some leading theorists in the bipolar field have posited that the range, if you have a broader inclusivity criteria, may be as high as 7%. And there's a lot of critique of that, saying that is probably excessive. But probably it's somewhere between 1 to 3, 1 to 4% of the general population. We in psychiatry will certainly see an enriched population. So we're going to see more of this than if we were just in general practice. And part of this higher number is the idea that we may be including highly recurrent depression in the bipolar spectrum. Now, the reason why this matters is because bipolar disorder left untreated can be a highly lethal illness. 1 in 5 untreated bipolar patients will die of suicide, and that's very concerning, of course. And there are a lot of attempts made in both bipolar 1 and bipolar 2, more than in major depression, or unipolar depression as it's sometimes called. And that we know when we compare this to the general population, the suicide rate is considerably higher in the bipolar population. It's in fact 26 times higher than the general population. Now, the good news is that we can make an impact on this, especially with lithium, and we'll talk more about that when we get to pharmacology. Now, how is somebody going to walk into your office if they have bipolar disorder? Well, when we zoom back and we look at somebody with bipolar 1, now this is, again, remember, somebody who, bipolar 1, they have full manic episodes, okay? They're going to spend about 1/3 of their lifetime depressed and only about 10% of their time manic or hypomanic. So it's important to understand that, and again, 50% of the time without symptoms. So it's important to understand that this is largely a condition of depression. So about 2/3 of the time when somebody is symptomatic, they're going to be exhibiting symptoms of depression, whereas only about 20% of the time are you going to see those manic. If you include mixed states, maybe about 30% of the time of those states. So if you're in a psychiatric hospital, these are the states you're probably going to see. Usually when people come for care, they are presenting with depression. Now, bipolar 2 is a different situation because, of course, in bipolar 2, by definition, you can't have full manic episodes. And so you can only have hypomanic episodes, which, as you can see here, only show up a very small percentage of the time, about 1 to 2% of the time. Over half of the time, the person will experience depression over the course of their lifetime, and about the other half of the time, they're not. So in 99% of cases, if somebody comes into your office and they have bipolar 2, they are almost invariably presenting with depression symptoms. So this is one of the reasons why it's very easy to misdiagnose bipolar 2 as depression. If we don't go back and take a good longitudinal history, we don't get a good family history, and we don't pay attention to response to medications, it's very easy to misdiagnose bipolar 2. And in fact, it is often misdiagnosed for many years before it is accurately captured by a clinician. So in summary, we want to think about bipolar disorders as existing on a spectrum, ranging all the way from fully unipolar to fully bipolar 1 disorder with full mania and full depression. So we think of this as a spectrum, and rather than think of it as a mood disorder, I want you to think of it as an energy dysregulation disorder. You won't find that term in the DSM, but I think that's a better description of the phenomenology that we see. And it probably affects about 1 to 3, 1 to 4% of the population, and most of those people, when they come to see you, are going to be presenting with depression. In our next talk, we'll talk about how to diagnose this in a systematic way and to look at the patient's history and presentation to understand where somebody might fall on that bipolar spectrum. Thanks for your attention.